Okay, good morning, everyone. It's a pleasure to be here at ECHO, at a pre-ECHO symposium. I remember being at one of the first ECHO meetings over 15 years ago in a small auditorium in the AMC, and it's amazing to see how this meeting has grown and changed into such a large meeting, and one of the best IBD meetings, I think, to attend. All right, so we're going to change gears a little bit and speak about how steroids work and how our approach to steroids has been integrated into our clinical trial designs. So as you can see from this slide, IBD is obviously very complex. It's a heterogeneous disease with multiple inflammatory inputs and pathways. And this is just sort of to give you an overall sense of the complexity and the broad nature of the inflammatory pathway through pro-inflammatory cytokines, our adaptive and innate immune responses, and how epithelial cells interact with our microbiota, which is our current hypothesis of why IBD occurs, leading to some structural or functional change in our microbiome and intersecting with genetic susceptibility to cause this unregulated inflammatory process. And there seems to be multiple ways that we can block this pathway, as you've seen from all of the new molecules that are being developed through various cytokine monoclonal antibodies that block the interaction of these cytokines with their receptors and prevent a pro-inflammatory cascade from occurring. Now, what gives steroids their appeal, or at least did give their appeal early on, was that they're very broadly acting. So they shut down many of the inflammatory pathways that are relevant in inflammatory bowel disease, broadly affecting most cytokines that induce inflammation, and probably what accounts for the very significant sort of feeling of well-being that many patients feel upon taking steroids. And their main mode of action is through the glucocorticoid receptor, which is a receptor that's found in the cytosol of many cells, and leads to an activation of or shutting down of NF-kappa B, which is one of the key drivers of inflammation, and we'll get into that a little bit later. So switching to the clinical approach and how steroids came to be used historically, if we look back to many of the early trials, and these are trials that were done more than 20 years ago or 30 years ago even, and this was a meta-analysis that looked at a summary of some of the RCTs in steroids, and they do show a benefit, particularly in induction, or specifically in induction. You can see that in the ulcerative colitis trials that have been done, steroids are favored and are effective for inducing remission. And in Crohn's disease as well, although in this meta-analysis the overall result wasn't significant, we know that there are two very old RCTs that were done that have led to our use of corticosteroids in Crohn's disease. So we heard from Iris just earlier about the limitations of corticosteroid use, and from Tim about some of the inappropriate use. So there are many limitations despite their appeal with induction. They don't have perfect outcomes, as many of our therapies don't. They don't work in maintenance, and they have limited efficacy on healing the mucosa. And this is a study from Pia Munkholm many years ago, again, that looked at some of the natural history of outcomes in Crohn's disease with corticosteroid use. And as you can see, and I think this should reflect your clinical practice, that roughly half of the patients have a good short-term outcome when treating Crohn's disease with steroids in terms of remission. Another third will be improved, and you'll have about 20% of patients that don't respond. But if you look out to 1 year or longer outcomes, what you'll see is that of the patients that went into remission early on, only about half of those patients remain in remission, with the other half relapsing. And of the patients that improve, roughly 40% will relapse. So when you look at the overall outcomes, up to a third of patients by the end of a year may be steroid dependent, and only about 40% will have a prolonged response, with another 20% or so being steroid resistant. And I think that generally reflects my practice, and I think it is probably representative of yours as well. Now, if we look at the limitations regarding maintenance therapy, we understand that they're effective at inducing remission, but they've never been effective at maintaining remission, notwithstanding all of the toxicity additionally that go along with them. And the figure on the left is from the National Cooperative Crohn's Disease Trial, which was the trial that showed that they were effective at inducing remission for Crohn's disease. But in this trial, in this maintenance portion of the trial, they looked at how the various agents that were used after induced remission were effective. And actually, in this trial, none of the agents that were tested were better than placebo, including sulfasalazine, azathioprine, and certainly not prednisone. And on the right, you can see, again, an older study of budesonide, which is one of the newer generation corticosteroids with less toxicity, and it is effective at inducing remission in Crohn's disease. But this study, led by Gordon Greenberg, showed that the maintenance effect of budesonide was not effective. It did seem to have some benefit for 3 or 6 months after remission was obtained, but when they followed the patients out to 1 year, those patients relapsed, so it was no more effective than placebo. So indicating again that we should not be using either the old steroids or newer steroids to maintain remission for patients with IBD. Moreover, as we know now, our focus is on healing the bowel and getting that endoscopic remission. And these are data from quite some time ago that looked at the impact of steroids on the mucosa. And in this study, from 140 patients that were initially randomized with active Crohn's disease, again, we see that very significant initial induction effect. 90% of those patients had a clinical remission. But when you look at objective endpoints, whether it's biomarkers, you can still see there's biomarker activity in these patients with clinical remission. And of the patients that were in remission, when we looked at the endoscopic outcomes in this trial, you can see that 70% roughly of the patients still had evidence of ongoing active endoscopic lesions, with only about a third of the patients having an endoscopic remission at 1 year. So this really highlights, again, that illusion that we're talking about of remission, where patients feel better, and our clinical activity scores do reflect that, but the objective outcomes that we're looking at really don't reflect the goals that we're trying to achieve with therapy. So as we now try to understand why is it that steroids don't work effectively, we'll ask for your thoughts on this issue. From what you're aware of, what do you think is the most important mechanism for corticosteroid resistance in IBD? Why do steroids stop working? So you can vote now. Selection 1 is the underlying severity. The disease is just too severe to respond. Selection 2 is the steroid dose or bioavailability that we're using. Steroid 3 are inherited or genetic factors in the molecular pathway of corticosteroid metabolism. And selection 4 is acquired or transient effects of cytokines in the IBD pathway, so some type of escape mechanism. So let's hear what people think about this. Very quiet for a large crowd. All right, so it's interesting. Most of the people feel that it's some type of acquired or transient effect of cytokine, maybe some escape pathway, and I think that's a really good hypothesis. The others are also probably playing a role to some degree, and the truth is there is no correct answer because we don't really know why this occurs, and there probably is a role from each of these. And we'll just speak briefly about some of those. So why don't steroids work long-term when they have such a profound clinical effect short-term? So if we come back to how steroids work, as you can see, the glucocorticoid receptor is a cytosolic receptor, and it has many isoforms, actually, but there's 2 major isoforms, alpha and beta, and it's the glucocorticoid receptor alpha isoform that has most of its anti-inflammatory activity, and it works by inactivating NF-kappa B-mediated pathways and directly suppressing transcription of pro-inflammatory proteins. It's speculated by some that there are other isoforms, and for example, the beta isoform that actually has the reverse effect, or it does not allow for binding of glucocorticoid receptor interactions with steroids and prevents that anti-inflammatory effect from occurring. So that's one hypothesis, and maybe one of the major ones. In terms of bioavailability, there's been some early data, and our group looked at this quite a few years ago now, that MDR1, the multi-drug resistance 1 gene, is an important efflux gene that leads to pumping of therapy or drugs or other molecules out of cells. And there's been a couple of studies that have showed that MDR1 polymorphisms lead to increased efflux of various agents, including steroids, from the cell, preventing them from being as active as they should be. And maybe that's some process that's upregulated as time goes on. And then lastly, the hypothesis that many of you thought were really relevant, and that's that there's some constitutive upregulation of other pro-inflammatory cytokines that occur with increasing duration of steroid exposure that leads to a more pro-inflammatory effect. And a lot of these mechanisms are related to, let's say, the mechanism of steroid refractoriness. We don't really have a good understanding of what leads to steroid dependence, which is those patients that do respond and can maintain a clinical remission, but cannot wean off steroids without an exacerbation of disease. So switching gears a little bit for the second part of my talk now, thinking about these mechanisms of action of steroids and their clinical effects in induction. How have the use of steroids been implemented in clinical trials, and how do we want to achieve our goal of steroid-free remission with our newer therapies? And it really, this cartoon sort of illustrates this idea that when we all look at something, we're all seeing something different. It's that subjective sense of what we're seeing that could be very different in different patients. And I sort of would draw the parallel to clinical trials. And when you look at a clinical trial result, you have the sense, well, this therapy is working, but when you really dig into it and look at what are the outcomes that are being described, we want to try to understand those endpoints in a bit more detail. So clinical trial design has really evolved over the last decades. If you think back to the early trials from the 1990s, they were generally short-term induction trials with only a few hundred patients and a small number of centers. And as time has evolved, trial design has really become quite sophisticated, initially looking at induction and maintenance sequentially, and then following into re-randomized responder approaches, more designed to reflect our clinical practice, and then into the more recent couple of years where there's been very sophisticated and complex designs with more drug arms, more active arms than placebo, and a lot of opportunities for open label. So really the trials have really become quite sophisticated, very large trials with over 1,000 patients in many cases. But underlying that design mechanism, we should also be thinking about what's being done with steroids. Obviously, many of the patients that are eligible for our clinical trials are on corticosteroids going into those trials. And again, back to the early generation of clinical trials, often corticosteroid-free remission was not even an endpoint, so it wouldn't have even been sort of reported as a significant endpoint or a pre-specified endpoint. And there was no designed or protocolized tapering regimen implemented in the trial at all. And then as time went on and we came to earlier trials, obviously corticosteroid-free remission now became an endpoint that would be reported in the trial, but the use of steroids and how they were handled during the protocol was not mandated, and it was at investigators' discretion frequently in these trials to determine how to taper the steroids, which could affect clinical outcomes. And then now we get into the more recent generation of trials, where, as I'll show you, there are very specific mandated protocoled approaches to dealing with the steroids and how they're tapered. So if we turn back to an earlier generation of clinical trials, and in this case referring to the CHARM trial and ULTRA trial for Crohn's disease and ulcerative colitis respectively with adalimumab, what you can see in how steroids were handled in these trials is that, first of all, the steroids weren't tapered during induction. The steroids were maintained at a stable dose through the first 8 weeks of the induction component of the trial. And then in the maintenance phase, it was really at the discretion of the investigator how they would taper, and there was no mandated protocol. However, we do see that steroid-free remission rates were reported. So you could see for Crohn's disease, roughly a third of patients achieved corticosteroid-free remission with adalimumab, and in ulcerative colitis, roughly 13% versus placebo, with up to 20% in responders who continued to taper off steroids during the maintenance phase. Now, probably the first study that really had a very specific approach to dealing with steroids was the Committe Trial led by Brian Fagan. And in this trial, this was sort of the sonic equivalent of combo therapy, where the investigators looked at the benefit of infliximab with methotrexate versus infliximab monotherapy for Crohn's disease. But what was unique about this trial design was that many of the patients were on high-dose steroids going into the trial. The average dose was more than 20 milligrams of prednisone, and there was a mandated tapering starting at week 1 after initiation of the trial. So it was quite an early tapering approach, and there was a very specific protocol such that all patients had to discontinue steroids by week 14. And this trial actually had some of the best clinical outcomes and corticosteroid-free remission outcomes of any trial, possibly because of that high-dose steroid being used very early, and infliximab and methotrexate being used early, and the steroids being tapered in a very systematic way early on in the trial, such that over 50% of patients achieved a steroid-free remission rate in this trial. Now, if we move down the road a little bit further, and using this approach of a very protocolized and mandated taper, we can see here the Gemini trial with vedolizumab for ulcerative colitis and the Pursuit trial on the right for golimumab in ulcerative colitis. And in these trials, there was a mandated taper of steroids starting at week 6 in both trials, so towards the end of induction. And then you can see that now there is an improvement with this earlier mandated induction, mandated taper protocol. You can see that the steroid-free remission rates get up to 30 to 45% with vedolizumab and roughly 30% to 40% with golimumab. So we're starting to see now creeping up of that steroid-free remission rate with the early induction and mandated taper. And now we turn to the Serene Trials, which again are even earlier or more recent studies. And what we can see here is that now the steroid induction has been moved up further. So again, this is what we want to achieve in clinical practice, start to taper our steroids as soon as we introduce our steroid-sparing agents. And so on the left with the Serene Crohn's disease trial, so the steroid taper had to begin at week 4. So this is, again, even earlier in the induction of the trial with the adalimumab. And again, remember, this was high-dose induction of adalimumab versus standard dose. And you could see that the steroid-free remission rates, in this case measured at week 12 that you've seen presented last year, show that you get to about 50% steroid-free remission rates. And if you contrast this to the CHARM data that I showed you earlier, you can see that we're achieving better steroid-free remissions by getting that steroid use in early and tapering more rapidly. And on the right, you're getting a little sneak preview of the Serene data for ulcerative colitis and the maintenance data that's going to be presented in probably about an hour from now by Jean-Fred Colombel. And again, this was a similar protocol where steroids had to be tapered at week 4. And what you can see in this data, that looking at the week 8 responders and pushing out now to the maintenance outcomes at week 52, you can see that we're pushing those ulcerative colitis results a little higher compared to the ultra results, up to 38% steroid-free remission rates. And lastly, if we now refer back to the Varsity trial, which was presented last year, and we look at steroid-free remission, as you'll all remember, most of the outcomes in this trial favored vedolizumab over adalimumab in treating ulcerative colitis. But there was this somewhat paradoxical result with the steroid-free remission favoring adalimumab. It was not statistically significant, but certainly for a lot of people, we puzzled over why this result occurred. And I think one of the problems that leads to the confusion in this trial is that there was no mandated steroid tapering protocol. So it was at the investigator's discretion what was done with the steroids, which may have led to this type of result being paradoxical as compared to the other results. And if you look in the supplementary materials and you look at the steroid exposure, what you could see is that cumulative corticosteroid exposure actually was more significant in the vedolizumab group, with their patients on vedo having 440 milligrams cumulatively more exposure during that year of treatment, and also having 24 days more steroid exposure than the vedolizumab compared to adalimumab treated patients. So it's a difficult study to interpret in light of this non-mandated or non-protocolized steroid approach, and this would really reinforce the importance of having this type of approach in our clinical trial design moving forward. So to summarize then what we've talked about today, steroids are effective at improving symptoms, and they do provide this global sense of well-being and improvement in how people feel. However, they are ineffective for maintenance therapy, as I've shown you from the data, and as you've seen, the toxicity can be quite significant in many patients. We don't really understand the mechanisms for steroid dependence and resistance, so the best approach would be not to allow our patients to even get to that point in the first place. I think you've all seen now the relevance and importance of corticosteroid-free remission as a critical endpoint in our trial design, with a very rigorous approach to how steroids are handled in trials so that we don't have this confusion in our results and how to interpret them. So thank you very much.